everyone to the genetic cardiomyopathy sub-session of this rare conference disease day at the Ottawa Heart Institute. It is 3:30, last session of the day, so congratulations to the people that have made it through the marathon of the day. We're going to get started here shortly. My colleague, Dr. Tremblay-Gravel from the Montreal Heart Institute is joining us as a co-moderator, and he will be introducing the session today for you. And we have a stellar lineup of speakers coming from various angles to cover this pretty wide topic that we can take in many directions, but we chose to have a little bit of variety today.
Thank you very much, Sanela. Can you guys hear me well? Yes, perfect. So let's get started. Good afternoon, everyone. And this session is genetic cardiomyopathy. My name is Maxime Tremblay-Gravel, as Sanela just said, and I'm very pleased to be co-chairing. We both specialize in advanced heart failure and cardiomyopathy. I work at the Montreal Heart Institute and Dr. Music at the Ottawa Heart Institute. And over the next 90 minutes, we'll be exploring genetic cardiomyopathies from very complementary angles, from susceptibility and ethics in testing to the intersection between genetics and inflammation. So this is going to be very interesting. Our goal is to move from mechanisms to real-world management questions, particularly in desmosome and inflammatory phenotypes that are kind of reshaping how we think about these diseases nowadays. And each talk will be 20 minutes long, 20 to 25 minutes long, followed by 5 minutes questions. Please feel free to post questions in the chat throughout the session. And you can also raise your hand at the end of the sessions to ask them yourselves. So I'll let Dr. Music introduce our first speaker.
Great. So first up, we have Dr. Annie Hung, who is our superstar advanced heart failure transplant fellow here at the Heart Institute. And she's going to open it up for us on a talk about genetic susceptibility and perhaps rethinking some cardiomyopathies that get labeled as acquired and how much of them may have a genetic underlying mechanism contributing or increasing susceptibility to acquired cardiomyopathies. I'll let you take it from there, Annie.
Thank you, Dr. Music, for the very kind introduction. I just want to check whether you can see my slides. Perfect.
Yes.
Perfect. Thank you so much. As Dr. Music mentioned, my name is Annie. I'm the Advanced Heart Failure and Cardiac Transplantation Fellow here at the Ottawa Heart Institute. My talk today is titled Genetic Susceptibility in Acquired Cardiomyopathies, or 2 Hits, 1 Heart. This is a brief outline of the talk today. We'll dive into what the 2-hit hypothesis means. We'll explore some common acquired cardiomyopathies, and then I'll leave you with some take-home points at the end. I have no financial disclosures. And so the 2-hit hypothesis, what we once thought were acquired or so-called secondary cardiomyopathies, have actually been shown in recent years to have genetic contributors. And this leads us to the 2-hit hypothesis or second hit theory. So the thought is that patients may have a genetic susceptibility or a first hit that puts their myocardium at risk of specific stressors, which act as a second hit. And together, these can combine to lead to clinical cardiomyopathy. And that makes sense, right? We know that not every patient who drinks excessively, not everybody who picks up a viral infection or goes through pregnancy, for example, develops alcohol cardiomyopathy, myocarditis, or peripartum cardiomyopathy. And in fact, research has shown that up to 15% of all patients with these acquired cardiomyopathies may actually have pathogenic or likely pathogenic variants, which we know to be associated with dilated cardiomyopathy. In addition to an isolated pathogenic or likely pathogenic gene, so as opposed to just one gene, we also know that oligogenic or polygenic risk may also play a role. So in this situation, it would be a combination of different genetic variants as opposed to one single pathogenic variant. And together, again, these genes may have a synergistic effect and again, put the myocardium at risk of a second hit. And so the penetrance of a pathogenic gene, or I guess if you frame it a different way, the development of actual clinical cardiomyopathy may very much depend on the at-risk myocardium becoming exposed to a second hit. And that's highlighted very nicely in this figure published in JACC Heart Failure 2025 by McNally. And so what they highlight is the genetic underpinnings, so a primary pathogenic or likely pathogenic variant, and as you'll see as a common theme coming up, the titin truncating variant is quite implicated in many of these cardiomyopathies. And when combined with other stressors such as pregnancy, infection, chemo, immune disorders, that can all lead to the development of the phenotype. And so in addition to that first hit genotype and a second hit from the environment, we also know that epigenetic changes to a patient's DNA or genome may alter how genes become expressed. And there's a thought that this may also play a role in the clinical presentation of cardiomyopathies. So any one given individual's unique combination or overlap of genotype, epigenetics, and stressors may explain why some patients with a gene variant, oh, sorry, there's just an announcement overhead. My apologies for that. So as I was saying, you know, this combination or the overlap of these three factors may explain why some patients with a gene variant never manifest any sort of clinical disease, or why some people develop maybe only structural changes on imaging, but not the clinical syndrome, or perhaps why others actually develop full-blown cardiomyopathy. And this may also explain why we get variable clinical expression or different age-related penetrance as well. So as an example of this, we know that even within single families with a very strong history of cardiomyopathy, not every member will develop clinical cardiomyopathy, or perhaps not as severe a degree as the proband. Some of the family members may actually present very early in life and others very late, and perhaps this might be a reason as to why. And so this flowchart by Heymans and colleagues on the left side here summarizes this quite nicely. So again, you have your predisposing factors, and perhaps the at-risk myocardium can compensate for some time. But when it becomes exposed to these non-genetic toxins, hormonal factors, or infections, I can hear another announcement coming. I apologize again.
Don't worry, Annie, I haven't heard them. So
Me neither. So keep
Oh,
going.
okay. Okay, perfect. Sorry, it's very loud in the room. And so the flowchart basically highlights that perhaps the myocardium is at risk and it stays compensated for some time, but then it's not well designed to put up with stressors. And when it becomes exposed to stressors, the myocardium fails and you get, again, the clinical heart failure syndrome. And so we'll go through some cases here. I'll start off with peripartum cardiomyopathy, which is a very common thing that we see in our clinical practice. And as many of you know, this is defined as heart failure with a reduced ejection fraction without any other cause. So it's a diagnosis of exclusion. It typically occurs during the peripartum period, which is classically the last month up to 5 months post-delivery termination or miscarriage. And it's not uncommon, actually. It affects up to 1 in 2,000 pregnancies, and despite all our medical advances, remains quite a leading cause of maternal death. The pathophysiology, we're still not quite sure. It's not entirely clear. It is proposed to be related to hormones that are released from the pituitary and placenta in the peripartum period. And so the question is there a genetic factor that perhaps makes some women more susceptible than others? And so I'll talk you through the case of Mrs. P, and I'll preface this by saying some details have been changed and there's no identifying data here. But Mrs. P first presented many, many years ago now with decompensated heart failure, and she was not known for this. So the first time she ever presented with heart failure was during pregnancy, and she was very quickly labeled with peripartum cardiomyopathy. And like up to 10% of women who do develop peripartum cardiomyopathy, she had a pretty severe course, and she ended up being crashed onto LVAD and bridged to heart transplantation. Now, thankfully, she's done very well for many, many years. But because at the time that this occurred, genetic testing was quite hard to come by, and it wasn't really pursued for her. But now she's coming back to clinic, and her daughter is married now and thinking about starting a family, but absolutely terrified of the thought of pregnancy because of what happened to her mother. And so Mrs. P is wondering if the same thing that happened to her could happen to her daughter. And the summary of peripartum cardiomyopathy from the ESC highlights very nicely that family history is a well-known risk factor for developing peripartum cardiomyopathy, and that in itself suggests that there's an underlying genetic cause. And in fact, up to 15% of women with peripartum cardiomyopathy have genetic variants which are known to be associated with dilated cardiomyopathy. And we know that phenotypically, they very closely resemble each other. And naturally, a lot of women who happen to present for the first time in pregnancy get labeled as peripartum cardiomyopathy. But in fact, they might actually have an underlying genetic cardiomyopathy, which only manifested itself with that second hit from the physiologic stress or hormonal stress of pregnancy. And so a lot of research has been done, and they have found that there is an overrepresentation of genetic variants, primarily in the titin gene, filamin C gene, and desmoplakin genes in peripartum cardiomyopathy. And as I mentioned before, the titin truncating variants do seem to be the most common. And the prevalence of many of these genes in women with peripartum cardiomyopathy is very similar to the prevalence of these genes in DCM cohorts, again supporting the similarity between the two diseases and really highlighting the fact that genetic testing should be considered in women presenting with peripartum cardiomyopathy. Now, it's not entirely clear at this point how these variants cause disease or how penetrance varies. Goley and colleagues showed in their research that the presence of this titin truncating variant, it doesn't seem to affect the severity of peripartum cardiomyopathy. It doesn't seem to affect the degree of recovery. So this again supports the idea that a second hit, or perhaps even multiple hits, contribute to the development of the clinical syndrome. And so going back to Mrs. P, she was counseled in clinic and ultimately decided to undergo genetic testing. And she was actually found to have a pathogenic variant in the titin gene. So what does this mean for her daughter? So now that a pathogenic variant has been identified, cascade testing of her daughter and other family members can be pursued. And if the daughter doesn't carry the variant identified in the proband, her mother, it's actually quite reassuring, and it may prevent her from undergoing extra unnecessary testing during her pregnancy. And so I'll move on now to alcohol cardiomyopathy. So this is essentially a dilated cardiomyopathy, but with a history of prolonged and quite heavy alcohol consumption. This definition is actually more than 80 grams of alcohol per day for at least 5 years. And depending on what country you're in, that can be anywhere from 5 to 10 units of alcohol per day. And for the diagnosis to be made, the patient should have excess intake at the time of their diagnosis or be within 3 months of reducing or quitting their alcohol use entirely. So I'll introduce you to Mr. A. He actually first presented with cardiogenic shock and ventricular tachycardia in his early 20s. And at that time, he was drinking up to 1 large bottle of liquor every night, along with stimulant use. And so he was very quickly labeled as an alcohol or toxin cardiomyopathy. Thankfully, he improved with medical therapy and initial abstinence, but his ejection fraction never actually fully recovered over the many years that he has been followed. And in fact, he actually continues to drink alcohol on a much lesser scale, but there's still some exposure. And he came to clinic one day asking whether the same thing could happen to his brothers, some of whom he noted were drinking quite heavily. And so this paper was published in JACC in 2018 by Ware and colleagues, and they were able to demonstrate that almost 14% of alcohol cardiomyopathy patients had at least one genetic variant in genes known to be associated with cardiomyopathy. And again, the Titin truncating variant was the most common, accounting for almost 10% of these patients, and in a similar frequency as in dilated cardiomyopathy. Now, interestingly, when they looked just at the dilated cardiomyopathy group, so these patients did not have enough alcohol intake to qualify for the alcohol cardiomyopathy diagnosis, but these patients, they looked at them if they had just the Titin truncating variant only and found that their EF was about 40%. If they had just excess alcohol intake, they found the EF was close to about 38%. But if they had both Titin truncating variant and excess alcohol, they had a much lower ejection fraction of about 28%. And so what this tells us again is that Titin truncating variants represent an important genetic predisposition to the effects of alcohol on the heart or alcohol cardiomyopathy. And these findings support that second hit model, with the first hit putting the myocardium at risk of a second hit to produce that clinical picture. And their findings of similar rates of dilated cardiomyopathy genes in alcohol cardiomyopathy really support the importance of obtaining a thorough family history when you meet these patients, and that genetic testing should be considered in these patients as well. And so going back to Mr. A, he again was counseled and decided to undergo genetic testing because of how the results might impact his family members. And as a result of this, he was found to have a pathogenic variant in Titin. And so his family members actually also underwent screening, and some of them were also found to have this. And so they were counseled on lifestyle modifications. And the hope is that maybe by being able to avoid the second hits and knowing that they are at risk of this, we can hopefully prevent clinical heart failure or a catastrophic cardiomyopathy presentation in his family members. And so I'll touch upon a few more so-called acquired cardiomyopathies. Cancer therapy-induced cardiomyopathy is something that we recognize more and more now, and it's something that we also see quite commonly in practice. Garcia and colleagues found that up to 7.5% of patients with cancer therapy cardiomyopathy had a Titin truncating variant, compared to just 1.1% of patients with cancer but without cancer therapy cardiomyopathy. And of the patients with cancer therapy cardiomyopathy, about 90% of them actually received anthracyclines, again supporting that first hit, second hit hypothesis. That being said, predicting individual patient susceptibility to developing this is still challenging. It would be really nice to be able to use this in a more definitive way if it comes to counseling, but we still don't quite fully understand why some patients with this develop CCM and others don't. What they found, though, was that the patients who had a Titin truncating variant seem to have a worse ejection fraction. They seem to have more AFib and more heart failure related hospitalizations, but it didn't seem to affect the degree of LVEF recovery. So again, maybe this will be elucidated further in ongoing research. In terms of myocarditis, there have actually been pathogenic variants in genes associated with dilated cardiomyopathy, non-dilated LV cardiomyopathy, and ARVC found in up to 22% of patients. And Loda and colleagues within their own study showed that 1 in 13 patients with acute myocarditis had a variant in a gene linked to DCM or arrhythmogenic cardiomyopathy. And so what they did was they had healthy controls, and they had a cohort of patients in London with myocarditis, as well as a cohort in Maastricht with myocarditis. And they found an enrichment of arrhythmogenic genes dilated cardiomyopathy truncating variants and titin truncating variants when compared to the healthy controls. They also interestingly found a trend towards greater all-cause mortality in the genotype positive patients, although this wasn't significant, statistically significant. So again, supporting the idea that perhaps genotype positive individuals may remain clinically silent until a second hit occurs and they're no longer able to compensate. And one other acquired cardiomyopathy I want to touch upon is the idea that systemic immune disorders may act as a second hit for dilated cardiomyopathies. And so Strokes and her colleagues demonstrated recently that more than 20% of patients who presented with autoimmune diseases and dilated cardiomyopathies had pathogenic or likely pathogenic variants. So these were patients who had diseases such as Sjogren's, lupus, psoriasis, autoimmune thyroiditis, gout, for example. And interestingly, the autoimmune diagnosis in these patients, on average, was diagnosed 4 months before they were diagnosed with dilated cardiomyopathy, suggesting that the associated inflammation may have served as a second hit to a genetically at-risk myocardium. And they were also able to demonstrate the synergistic effect of having both factors, similar to Ware and colleagues with the alcohol cardiomyopathy. So what they found was that in patients with both the titin truncating variant and systemic immune disorder, they had a statistically significantly lower LV ejection fraction compared to patients who just had a systemic immune disorder or just had a titin truncating variant, for example. And so I'll leave you with some take-home points to wrap up here. We've talked a lot about the two-hit hypothesis, and we understand a lot better now that many of these so-called acquired cardiomyopathies have underlying genetic similarities to dilated cardiomyopathies. So again, the genetic variants may serve as that first hit, which then become compounded by the second hit. And that second hit could be other genes, epigenetic changes, environmental stressors, alcohol, hormonal changes, chemo, inflammation, and so on. And so for this reason, it's really important not to simply label patients as an acquired cardiomyopathy and just move on without considering the possibility of an underlying genetic cause. And this is really important because it could have implications for screening and care of their family members and loved ones. And in some cases, it may also affect management of the proband themselves. So we know, for example, there are certain genetic variants in desmoplakin genes, for example, which may actually push you to pursue a primary prevention ICD beyond the classic indications that you see in the guidelines. And so diagnostic workup of any cardiomyopathy should always include a thorough family history. It should focus on both genetic and other acquired factors or stressors. And the hope is that with all this information, we can hopefully help our patients avoid a second hit, which may ultimately be life-threatening or life-altering. And thank you very much.
Great, thank you, Annie. That was a great talk and something that's could definitely go on for an hour if you really want to get in the weeds on the evidence of any single one of those. And maybe open the questions to my co-moderator and our other speakers about how you approach some of these acquired cardiomyopathies. What is your threshold for genetic testing in these patients? I think we don't have enough to say we should just genetically test everybody, but certainly perhaps we should lower our threshold in some of these cases because, as Annie mentioned, labels tend to stick. And these are two of my patients from clinic. One was a transplant patient, 20 years post-transplant, who just told me her daughter was paranoid about pregnancy. And that's what brought on the conversation. Thoughts from our moderator and speakers on this?
Yeah, I don't see any questions in the chat, but I have a question. My threshold is quite low to do genetic testing in these cases, but I guess it all depends on accessibility also, depending on where you work. But threshold is low. But my question for you, Annie, would be if you have a patient with a lot of non-genetic factors, causing DCM and your genetic testing is negative, or maybe you have a very low impact VUS, would that affect your family member screening or not?
Yeah, I think that's a really great question and probably involves a lot of shared decision making with the patients. And many of these patients often bring their family members to clinic as well. It's I would say, genetic testing has evolved a lot over in recent years, but we still often we don't know the full picture yet. And we know that when we retest some of our patients, like 5 years or 10 years down the road, our panels are so much better now that they actually pick up new variants, for example, that we then realize are actually likely pathogenic. And so I would say that it would still be important to counsel their family members on avoiding, just healthy lifestyle or lifestyle modifications that they might be able to make in case they are at risk. And for your own patient, it may be worth re-exploring repeat genetic testing down the road in case that changes anything for themselves or for their family members.
Yeah, that makes sense. I say that my threshold is low for genetic testing, but I also keep in mind that if I see a patient with chemotherapy, a high alcohol component, and then the genetic testing is negative, I just keep in mind that maybe I won't screen family members every 3 years for the rest of their lives compared to 18-year-old who presents with a very severe cardiomyopathy that's completely idiopathic, then I would probably do a more aggressive family screening. But on the other hand, if you have a patient with like lots of external environmental factors, but you do happen to find the Titan variant, maybe it's still worthwhile to do some cascade screening in the family well, probably it is, even though there were a lot of environmental factors. So yeah. Are there any other opinions in the room or Sanela? Yeah.
No, I think I would agree with everything you said, and I think we find out more about these things every year, and I think it's harder to undo a label of acquired than anything else. So just kind of avoiding the anchoring error of diagnosis is always first on my book. It's actually a perfect segue to Melanie's talk, who's going to talk to us about ethical and clinical dilemmas in genetic testing and counseling and some of these gray zone areas, right? Where we're trying to do our best to counsel the patient and the family with our current state of the evidence, but there's still so many gaps and unknowns. So Melanie Kerr is kindly agreed to do the talk today for us, and she was also in the inherited arrhythmia session right before this, so she's in high demand. She has a wealth of experience in genetics with over 25 years of work at the Peter Munck Cardiac Center in both the inherited arrhythmia and the heart function clinic, helping to really bolster their genetic testing program. She is also very well known internationally, has authored several peer-reviewed publications, including of note most recently the CCS CPU on cardiogenetics, of which she was the first author. So without further ado, I will let Melanie take the floor.
Thank you very much, Sanela. Can I ask you to give me permission to share my screen? Maybe.
Oh, I've updated the controls, so it should work now. And
Perfect.
if not, I've got your slides.
I think it's working now. Just give me a second. I just have to pull up the right screen. And I think that will be it. Is that showing my title slide? Yep. Okay. Amazing. Thank you. Again, thanks so much for the invitation, Sanela and Maxime. I really appreciate it. I'm always happy to share some of my past experiences when it comes to genetic testing and genetic counseling and inherited cardiomyopathies. And again, to highlight, I mean, the title of this session was called Clinical and Ethical Dilemmas. I sort of pulled that out a little bit and think about clinical considerations, because I think those clinical and ethical dilemmas are baked into all of this. And, also to recognize that this is always, it's an ever-changing landscape. And so we learn as we go. And this is kind of where we're at today. And I expect over time, we're going to have other considerations moving forward. So I have no disclosures to report. And so I wanted to put this in kind of as practical a context as I could. And so I think there's a few things that are important to think about in this evolving field of genetic testing for cardiomyopathy. So I want to talk about the evolving eligibility guidelines. I think this is a really good follow-up from what Dr. Hung was talking about and what some of the discussion was there after the last session. How to access testing. This is going to be an increasingly challenging thing to consider, I think, within our system. Considering what kind of testing to order. There are options, there are differences, and it comes with different results. Talk about the interpretation and management based on those results, and a little bit about family risk assessment and cascade testing. So this has been a huge shift in the landscape, I think, in the last few years in terms of who we consider appropriate candidates for genetic testing. Historically, we really looked at those people with young ages of diagnoses, strong family histories. Many of the cardiologists I work with wouldn't even consider genetic testing unless there was an exceedingly strong family history. But there have been some pretty important publications in the last couple of years. And this is just one of them, but these are the 2023 European Society of Cardiology guidelines for the management of cardiomyopathy. And what we see is that we're starting to have some class 1 recommendations for genetic testing in what are pretty broad categories, right? And so, we see that genetic testing is recommended in patients that fulfill diagnostic criteria for cardiomyopathy, where it enables diagnosis, prognostication, therapeutic stratification, et cetera. That applies to a very large population of people. It's even a class 2B recommendation when it may have a net benefit for patients considering psychological impact and preference. And so ultimately, this starts to look like a very, very large population of people who are technically and guideline recommended eligible for genetic testing. Ontario also has some specific guidance now for anyone who is working in our province. This was put out just over a year ago. The website is here. You can access the whole document online. This is publicly available information. They've broken that guidance into various diagnoses. So they talk about HCM versus DCM versus arrhythmogenic cardiomyopathy. I've highlighted or pulled out the criteria for adult DCM because without sort of reading it verbatim, you'll see that it's very, very broad. So at the end of the day, we're being told that most patients with a diagnosis of dilated cardiomyopathy are eligible for genetic testing. So this is moving on to the next, I would call it both a dilemma and an ethical issue, which is access. How do we get access for people to genetic testing who are technically eligible? And based on, we just heard from Dr. Hung what those high detection rates are in some of those populations where we previously did not believe there was a genetic component. So there is value across the clinical spectrum of genetic testing. And I think anyone who's been working in this field has seen how that really has come to pass over time and how significantly high some of these positive rates are. But when we think about access to genetic testing, historically, certainly in our country, and I think other jurisdictions as well, there's been this sort of pathway to genetic testing, this sort of this system whereby genetic testing is housed within genetics clinics or some, in the case of inherited heart disease, very specialized expert groups of inherited arrhythmia, inherited cardiomyopathies. But really for the majority of people, what it has meant is that we've got a cardiologist who does an assessment, provides a diagnosis. They send a referral to a siloed genetics clinic where we have genetic counselors and medical geneticists who can facilitate the testing, do the appropriate genetic counseling. A result comes back, which is then sent back to the cardiologist. And it has been very siloed like that, but it results in some real challenges in terms of lengthy wait times. I think there's not there's not a cardiologist in this country that I haven't heard talk about the frustration of trying to get access to genetic testing for their patients, to the point where a lot of them just don't do it, right? They just say it's not worth it because they sit on a wait list for 2 years and nothing happens. We get lost referrals. We have geographic challenges in this country. And so with this siloed approach, we're losing a lot of people. With these expanding guidelines, this is no longer going to be an appropriate model. And we really have to start thinking about how we can bring people into the system and give them access to this testing in different ways. And that was one of the things that we did try to address in the clinical practice update that Dr. Music referenced that was published in December, looking at some of the different pathways that we can start to think about to allow people access. And there will always be a place for a referral to a specialist. The question is, what is the right time to refer them to that specialist, and for which of the patients are going to benefit most from those specialized services, versus where can we start to look at putting genetic testing at point of care? Right. And so I think this is something that we are all going to have to talk about. And this is going to evolve very quickly, I think, because of the overwhelmingly increased access that is coming. And certainly in Ontario, I don't know if that's where the majority of people here are from, but this is now very clearly available to any cardiologist can order this. The issue is this, and I said this last hour, and I will say it again, because I said every time I get an opportunity to stand on this soapbox, I will. Genetic testing, absolutely just a blood test. From a patient perspective, from an ordering perspective, you fill out a requisition, you get a test. But it's much more than this, because there are very substantial nuances to how to interpret this testing in the context of a genetic test report itself, but also in putting it within the context of a specific patient. So this is not often, I mean, it can be, but it's not often a definitive yes or no. It can often result in a we're not sure, a maybe this is genetic, maybe isn't. And how we interpret those findings can significantly impact a patient's risk. Inaccurate interpretation can result in mismanagement of patients and their families. And because we're dealing in this particular group of conditions that can have very catastrophic onset and catastrophic first presenting features, we really want to be thoughtful about that. And so we want to manage our expectations. We also want to start to really help the broader population of cardiologists and providers in understanding the nuances of this. I feel really passionately about this because I think access is so, so important for this population. So what I thought I would do briefly here is talk about a family. I'm going to talk about a single family and 3 possible outcomes from genetic testing, what was done, how it was done, and what the results were. And while this particular family is a conglomeration of a few, so it's not one specific family, every single one of these outcomes is a realistic and possible outcome in these settings. So they're not made up, they're not to make a point, these are things that actually happen. So again, kind of a nice, I didn't realize exactly what Dr. Hung would be talking about, but it works out kind of nicely because we have here a woman, a 60-year-old woman who has had past treatment for cancer with chemotherapy, and the working diagnosis for her has been a chemotherapy-induced cardiomyopathy. She's referred, the cardiologist felt that maybe it was a little bit out of keeping with what they might expect from her past treatment. And so certainly when I saw her and extracted a family history, there were some details here that made it a bit suspicious, right? So she has this sort of uncertain history of a cardiac cirrhosis in a sister and a nephew who had a heart transplant. I do want to say at this point that this is by patient report only. So we have to be very thoughtful about how we interpret the reports from families and what their histories actually are without having an opportunity to review their clinical findings. So just always keep that in mind when we're looking at family histories and pedigrees. So the first thing we want to think about, like, what are our testing options, right? How are we go about this? We have a woman with a dilated cardiomyopathy that's chemotherapy associated. And we can go a few ways with genetic testing, right? We can do small targeted panels. These are based on the presenting phenotype. And if you look at genetic test requisitions across various clinical laboratories, you often will see them broken down. You can order an HCM panel, you can order a DCM panel, you can order an ARVC panel. The sizes of those panels are different. The gene content is slightly different depending on the clinical presentation. Oh, sorry. You can order, on the other hand, large multi-gene panels. So they'll put all of those genes together in one large conglomerate of all genes ever thought possibly may be related to cardiomyopathy. And here's 215 genes, have at her. There are things to think about. There are downstream implications to making these kinds of decisions. So just to take a step back again, kind of historically, we really looked at these clinical entities quite separately. There were clear genes for ARVC. There was a clear set of genes for hypertrophic cardiomyopathy, different set for DCM, little bit overlap. We've always kind of recognized a little bit of overlap here. But there was a very, very siloed approach that was strongly based on the clinical presentation of that patient. Over time, what we have come to appreciate is this is far more what it looks like now. So, we recognize through time, experience, research that genes that were historically believed to cause ARVC specifically actually can present with what was initially called a left-sided ARVC, or maybe now just an arrhythmogenic cardiomyopathy. So we've gone from these sort of siloed panels to an appreciation that there is a lot of genotype and phenotype overlap within the space of hereditary cardiomyopathy. So this is an important consideration because depending on what panel is ordered, you get different kind of results, right? So if you do a small panel, you have a very high gene-specific specificity, and you're going to get a more disease-specific result. And in some clinical circumstances, this makes sense. If there is a clinical condition for which there isn't that much overlap genetically, a smaller panel, I would argue, and again, this is an opinion, it's also out there, one woman's opinion, this makes more sense. A hypertrophic cardiomyopathy, for example, we know quite clearly the primary genes associated with HCM, and to look at genes in other types of cardiomyopathies can result in more confusion than actually clarifying a situation. On the other hand, if we have a more general dilated cardiomyopathy diagnosis, there is not a lot of specificity there in terms of genes. And so that probably makes more sense to go a bit bigger, a bit more broad, but recognizing that by doing that, you're more likely to get inconclusive or uncertain results, right? The more genes we evaluate, the more likely we are to identify variants that we're not sure of their clinical impact. And I would say that generally, all other cardiomyopathies besides HCM, that's probably the preferred testing strategy for most people. So this is a woman, dilated cardiomyopathy. The current comprehensive cardiomyopathy panel in Ontario is an 81 gene panel. And sure enough, we find a pathogen or a likely pathogenic in this case, TNNT2 or troponin T, likely pathogenic variant. So not Titin, not like what Dr. Hung was talking about, but one of the other cardiomyopathy genes. There's good evidence that this is associated with disease. So certainly that changes things a little bit for her and her family, right? We know that there's at least a primary genetic driver here, possibly in the context of that second hit, but we do have that primary driver. In some cases, this can alter management in terms of modified surveillance, or if one of those arrhythmogenic genes that was alluded to by Dr. Hung, it can change thresholds for ICD implantation and that sort of thing. In this particular case, while it may not do that, TNNT2 isn't on that sort of high-risk list, it does give her treating physicians an appreciation that this is an underlying genetic condition that's going to need ongoing management. moving forward. And of course, her first degree relatives are at 50% risk. Clinical screening is going to be recommended at a minimum, and genetic testing, which we often refer to as cascade testing for first degree relatives, is available. I would argue at this point, this is where, when it comes to cascade testing, not a bad idea at this to consider sort of involving some of the more specialty clinics, the genetic counselors, the medical geneticists, and or cardiologists who are working in an inherited setting, just because there are some different issues to think about when it comes to informed consent around predictive testing versus genetic testing in a person who already has a clinical diagnosis. So that's fairly straightforward. I would call that the most straightforward result. But I'm gonna add on here, and I'm gonna call it scenario 1A. And this is a family follow-up. And this is where sometimes things can sort of hit you out of the blue. So this woman looked after, everything's fine. A couple of months later, we get a referral for her niece who has mild LV dysfunction on an outside echo, but has this family history of confirmed cardiomyopathy. This is the information we get with the referral. So we have linked the two up. We know who this is. We say, okay, we can give you some testing here. We suspect that, I mean, if I'm a betting woman, I'm going to say you carry this variant, right? I mean, we can see this family history. So we go ahead, we test the family variant. What? And this is true. This part is true. This is not made up to make a point. So now this isn't making sense anymore. And we say, okay, well, you just had mild LV dysfunction. So maybe that's unrelated. But I feel like maybe we need to take this a little bit further. So let's talk to your brother who had this heart transplant. Let's interrogate his clinical situation a little more. Let's get genetic testing on him. Guess what? Negative. So here we have a family history that looks like everything's related to each other. And yet, when we follow through with some of this testing, we recognize there's more than one thing going on here. So this is just a cautionary tale, and this is something that's happened to me more than once. And I can get very lulled into thinking what is expected is what we will get, but it doesn't always play out that way. So whenever possible, it's really important to ensure that genetic and clinical results are concordant, both within individuals and within families. So very quickly, a negative result, we certainly see this in genetics all the time. We know that a genetic cause is not confirmed. We can't eliminate it, particularly when we have forget the last piece of it, but let's pretend this is new now. So particularly when we have a family history that is suspicious to us, we're not going to suggest this isn't genetic. We know there are limitations to genetic testing. That's real. Even though I would say that working in a laboratory setting, which I've done for the last few years, has really brought this to the fore for me. That's not just a caveat. We just say there are definitely limitations to genetic testing, and there are variants we don't understand, and there may be intronic variants that we haven't figured out yet. So negative genetic test results do not rule out a genetic diagnosis. First degree relatives, particularly in a family like this, may still be at 50% risk, and clinical screening is going to be recommended. Genetic testing, of course, unlikely to be helpful in this scenario. Like we were talking about, I loved that conversation in between after Dr. Hung's talked about when do we do clinical screening, right? Like that's difficult. In a family like this, I think we would say there's enough indication to recommend clinical screening for first-degree relatives of affected people. But at the same time, if she was an isolated case, that might change our recommendation. So genetic testing can decrease the probability of a genetic condition, but I just can't be ruled out entirely. So then we get to our most fun, of course, which is results that start to look like this. And we are seeing, I don't want to speak for others, but in our center, certainly when we are doing genetic testing now with these large panels, we can get these results of laundry lists of variants, right? That just are so confusing for providers to understand. It's confusing for patients. What do these all mean? And we have to put these through our lens. The first thing we have to recognize, of course, is that gene variant interpretation is probabilistic. So a variant of uncertain significance, even if it's in a gene that looks convincing to you, and I have these conversations all the time, oh, well, that's very clear cardiomyopathy gene. This is clearly the cause. That variant of uncertain significance can range from anywhere from 10% likely pathogenic to 90% or 89% likely pathogenic. And that's a huge box. So you have to be really careful and thoughtful about how we interpret these. They're not created equal. Some are hot VUSs. They lean towards being pathogenic, others less so. And it's important to put that in the context of your patient. I always like to talk about this a little bit, which is the importance of, just being aware of what genes are being tested that have really strong evidence for disease association. We have a lot of groups within international communities that are curating this evidence to allow us to do a really nice, quick search about the probability of a gene that we identify a variant in as being associated with a clinical phenotype. If you look at all of these genes, dozens of genes for dilated cardiomyopathy, we see that of the evaluated genes, only 12, at least in 2021, were considered to have definitive or strong evidence of association with DCM. Another 7 or so moderate, so leaning, but moderate evidence for disease association doesn't mean definitive, and those can go in the other direction also. But we see a ton that are as you can see, with limited evidence. And when we look at the genes in this particular patient, we see 2, an SCN5A and a Titin variant. Yeah, those genes are definitely relevant in dilated cardiomyopathy. TNNI3K at this time has limited evidence. I'll leave that there for another talk because that's a whole other issue. But we want to look at that. We want to look at that sort of critically. I do want to bring it back to Titin really quickly because that was highlighted so nicely by Dr. Hung, and truncating variants, particularly A-band truncating variants in Titin, are probably, if not certainly, the most common hereditary cause of adult onset dilated cardiomyopathy. At least in our population, we've shown that. This is not a truncating variant. So that has to be interpreted very, very differently. Missense, Titin is a massive gene. It's the biggest gene we have. There is a ton of variation within this gene, and the missense variants to date really haven't played out to be causative factors in dilated cardiomyopathy. So just because you see a Titin variant on a report, it doesn't mean it's going to be disease causing. So keep that in mind. When it comes to managing VUSs, we have to be really thoughtful, right? And I think for those of us that do this all the time, this feels like second nature, but I have conversations regularly with people for whom this is relatively new, and it's not second nature for people. So there are things we don't want to do with variants of uncertain significance. We want to be really thoughtful and be careful that we do not assume that that genetic finding is causing the disease. We do not want to use that for management making decisions, right? We don't know. This whole idea of genetic testing lives in a world of uncertainty, and at this point, we don't know. And if we make the mistake of using that variation to manage, clinically manage patients, we could get ourselves into trouble. And we also don't want to offer genetic testing for cardiac risk assessment to family members because we don't know that that's what's actually causing the condition in the family. What we do want to do is continue to base any clinical management on a clinical presentation. We want to interpret that genetic finding in the context of our individual patient and their family history and follow appropriate guidelines about cardiac screening and surveillance in first-degree relatives. There are some interesting things we can think about when it comes to looking at VUSs. We do want to think about targeted genetic testing for other affected family members, right? So in this particular family, if we were to see that the patient with the heart transplant has the same variant of uncertain significance, that starts to feel like, it doesn't feel like, that's evidence to suggest that there may be a connection there. You do need to see it in a lot of affected family members to be conclusive about it, but it starts to put the puzzle together for you. We want to lean into certain variants based on the evidence. Most certainly, we will manage some variants more aggressively than others because of the evidence in the family history. These are also the patients that I would suggest for cardiologists and care providers doing this perhaps outside of specialty centers. This is when you want to start to refer in to some of your expert colleagues for sort of a more comprehensive review of the genetic test results. I'm going to leave that for now. Actually, I'm going to leave all of that for now because I kind of come to the end. So I just sort of want to remind people I can run out of time very quickly, but I do just think it's really important that we need to think about how we are going to develop systems and strategies to provide access to genetic testing for patients in this space, because it's going to increasingly be embedded into mainstream cardiac care. And by utilizing these thoughtful testing strategies and interpretations, we're going to maximize the benefits for our patients while minimize the associated risks, of which there are some. So thank you so much for your time and attention. I'm always happy to answer questions. I do love talking about genetic testing. So thanks so much.
Thank you. I'll open it up to our audience if they have any questions for Melanie. Feel free to put it in the chat. If nobody has anything, then I'll pitch in. Thank you. That was very helpful and appreciate your time management. I know it's very hard to do a 20-minute talk on a topic like this. This is a very nice example to use, and I always struggle with segregation, non-segregation, unexpected results, and sort of, I find it hard also to move away from our kind of oligogenetic inheritance mindset and towards more polygenetic risk scores and that kind of thing. So what would be sort of your next step in a family like that? How closely would you follow them? How often would you reassess? Would you go ahead with some more advanced genetic testing to try to pinpoint what's going on?
Yeah. So I mean, every family's different. Every situation's different. How strong is the phenotype? How significant is it? I mean, without too much interrogation in that kind of family, we would certainly expand a full panel of genetic testing to the patient that had the heart transplant, right? And we have had scenarios where we have cousins who are both significantly affected, and they have two different variants coming from different sides of the family. So I would also, I almost hate to say it out loud, but I'm also increasingly in these situations when patients are kind of far removed, first cousins or further, I lean away from targeted testing now of known family variants, and on a very significantly affected individual in the family, repeat a full panel test to make sure that there isn't something else significant there. The other challenge does become in these situations, exactly when do you, if you're testing someone for a known family variant that's pathogenic, but there's also VUSs in that probands report, do you test the family members for those variants of uncertain significance? That's a talk on its own, and we can certainly debate that. But I think that there are benefits to doing some of them and others not. But again, it's specific, it's situational. And variant specific. A cold VUS, probably not. A hot VUS, we're going to think twice about.
Fascinating. I took notes, and I think I'm taking notes for topics for next year's conference. We could have a 20-minute talk only on that, and it would be very interesting. Thank you very much. I'll introduce our last speaker. Dr. Eric Smith from the University of Michigan. Dr. Smith is a cardiologist and physician scientist in the Inherited Cardiomyopathy program at the Frankel Cardiovascular Center. He did his residency, cardiology, and postdoctoral training at the University of Michigan, and also has a master's degree in human genetics. He does a lot of research on genetic cardiomyopathies and arrhythmia disorders, including desmosomal cardiomyopathies and the role of inflammation in their management. So I'm very eager to hear his talk. And the floor is yours, Eric. Thank you for being here.
Thanks, Max, for the invitation. And Annie and Melanie, those are great talks. There's stuff that I love to hear other people talking about, because we're like screaming from the rooftops here about how important the various modes of genetic testing, and how like the field is changing, and that our leaders need to be aware of that, and they aren't always as up to speed as we are. So can you guys see my slides okay? All right. So I'm going to talk about PKP2 and desmoplakin cardiomyopathies today. I don't have any disclosures related to this. So we'll go over the clinical presentations of DSP and PKP2 variants because they're a little bit different. Talk about this idea of hot phase inflammatory episodes in these desmosomal diseases because it's becoming something that is obviously affects patients, and how we manage it is not totally straightforward. And then I'll talk about how we manage these patients at University of Michigan. There aren't great guidelines for management right now. So just to back up a second, we're talking about arrhythmogenic cardiomyopathy, and this is a picture of all the different genes that are implicated. Today, we're focusing on the desmosome specifically, and the desmoplakin and plakophilin within the desmosome. So desmoplakin is here in purple, and it links the extracellular portion of the desmosome to intermediate filaments in the cell, and then plakophilin 2 is a linker between desmin and these extracellular components. But there are a number of other genes that are implicated in arrhythmogenic cardiomyopathy. So the desmosome you can think of as the heart's mechanical stress transducer. So it exists between cardiomyocytes, and it helps transmit force from one cell to the next. Desmosomes are present in other tissues such as the skin, also in the intestine. It's an important structure in any tissue that needs more strength. This is just a zoomed in picture of a desmosome here. And then desmoplakin and plakophilin are what we're going to focus on. So my foray into genetic cardiomyopathies started in clinic as a cardiology fellow. I had no idea that I was going to do any of this when I started fellowship. And it started with one family that's shown here who had something they called the curly hair heart syndrome. So they had noticed that various people in their family had cardiomyopathy, but that also those patients had curly hair, or those family members had curly hair. And it turns out that all of these family members have desmoplakin variants. So desmoplakin variants cause curly hair for whatever reason, and it's pretty easy to pick out family members because of that. And so I met this family, and then with my primary mentor, Adam Helms, we put together a series of patients a few years ago looking at the difference between desmoplakin and plakophilin 2 cardiomyopathies because they seemed very different. And all of the literature at the time referred to desmoplakin as a gene and a protein that causes arrhythmogenic right ventricular cardiomyopathy. But what we were seeing was more left ventricular disease, a different pattern of fibrosis, and then a high burden of arrhythmia that seemed to increase at ejection fractions that are higher, at an ejection fraction that's higher than what you would typically think is a risk factor for arrhythmias. So we compared that to PKP2 patients who have more right ventricular disease, RV dilation. Their arrhythmia risk relates to EF reductions on the right side to a more severe degree. But then patients have commonalities. They all have PVCs. There's a high rate of ventricular tachycardia. And this has been subsequently shown by a number of people. This is a study from Jack a few years ago that looked at a number of different genotypes, but I pulled out DSP and PKP2 here. 59% of patients with DSP variants had a dilated cardiomyopathy, whereas pretty much no plakophilin 2 patients had a traditional dilated cardiomyopathy. And then 80% of PKP2 variants had classic ARVC. And then there's pretty specific imaging findings in DSP. This is a picture from our paper from 2020 that shows this unique pattern of subepicardial fibrosis in the LV that happens in desmoplakin patients. This is from a study that was in circulation from 2025. And I just put it in here to highlight the difference between some of these genotypes. PKP2 is in green. It's kind of hard to see up here, but what you can see is that the curves diverge over time, and that patients with desmoplakin variants typically have a more severe disease course than patients with plakophilin 2 variants. But everybody, there's still a large number of patients that are experiencing events as life goes on. The other thing that I like to highlight from this, in most of these survival curves in these desmosomal diseases, is that the initial events, aren't occurring when patients are 10, 15, 20 years old. They're starting to occur in second, third, fourth decades of life. And so we think of this as a chronic progressive disease. It takes time for damage and fibrosis and changes to the ventricle to occur. And so events aren't happening early in life. There's, of course, exceptions. We have patients here who present in their early teens, but a lot of people are presenting in their 30s or 40s. And then this is from that same study, just to highlight that genotype matters, and there are variations in disease presentation with genotype. So just further confirming what we had initially shown in 2020, like here, PKP2 variants, 61% are lone ARVC, whereas DSP variants are 41% LV dominant disease. Both of these diseases can flip-flop. So as DSP variants cause severe LV dysfunction, as the disease becomes more severe, they can have RV dysfunction and then fall into a group where they have both ventricles affected. And then likewise, PKP2 variant carriers can initially present with ARVC, but then go on to develop left ventricular disease and more severe forms of the disease. And then desmoplakin, probably because it affects the left ventricle more and earlier on, more typically presents with heart failure. And then there are certain hotspots in these genes for missense variants. The majority of mutations are truncating variants, but because the proteins have specific binding sites, there are hotspots for missense variants that are more likely to lead to disease. So we're kind of shifting our thinking in desmosomal diseases from into this idea of immune-mediated problem. This is a picture from a deceased individual who was 32 with ARVC, and there are inflammatory infiltrates on autopsy. And this is a FDG PET scan that's extremely positive in a patient with a DSP variant and acute chest pain. And so while the proteins are important for this structural component within the heart, there's something else going on because there's a substantial inflammatory component to these diseases. And I think the University of Michigan Eric Smith theory on what's happening is a mechanical problem, and that inflammation is secondary. So what we've been working a lot on here, and the theory that we're operating under at the moment, is that you lose desmoplakin or plakophilin, and that sensitizes the cells to contractile stress and injury, and the cells tear apart from each other, injury occurs, and then inflammation is secondary to this process. And that conceptually sort of tracks with the chronic progressive nature of the disease. And then these inflammatory episodes play into this, and I'll get into that in a second, how inflammatory flares may worsen the disease as they occur, but the primary driver may be a mechanical problem and injury, or micro injuries within the heart that accumulate over time. So there have been these myocarditis or hot phase type episodes described in ACM, where you get myocardial inflammation, chest pain, troponin elevations, but no evidence of ischemic changes. And these are generally called, they present as acute myocarditis. If the patient has a cold at the time, sniffles, they're told it's a viral myocarditis. The episode resolved and they're sent home. But in reality, this may be an inflammatory event that's occurring because of potentially mechanical damage that's happening in the heart, and then this overwhelming response that the heart then tamps back down. It's more common in patients with desmoplakin variants compared to plakophilin 2. We showed this in our initial paper, where 15% of patients had episodes, but no plakophilin 2 carriers had episodes. That's been reported subsequently by a number of people. In this later study in JACC, they had a higher percentage of desmoplakin carriers with events, but did pick up some PKP2 variant carriers that had events. I think I don't have like data to point to for this specifically, but my personal opinion is that desmoplakin variant carriers probably experience these more because the primary insult is in the left ventricle and there's just more LV mass to create pain and troponin elevations. I certainly have patients with PKP2 variants that develop troponin elevations, but the degree of chest pain and like clinical recognition of the episode is less likely, and maybe that's just because it's happening primarily in the RV and there's just not as much myocardial mass. What's most important about these events, and I think what we're starting to understand, is that it's not good. When these events occur, they accelerate disease progression, they lead to fibrosis, and they, while they don't lead to arrhythmogenesis in the moment, it's becoming clear that arrhythmias, the risk of arrhythmia is increased after an event happens. And so we've been part of this Desperados cohort that was organized by Alessio Gasparetti at Hopkins after the initial DSP cohort that we published. And the first phenotypic explanation of DSP that cohort published looked at ventricular arrhythmia events post myocardial injury episodes, and there's a clear difference between patients without myocardial injury and those with, in that they develop more ventricular arrhythmias in the years following the event. And then that was also shown in a JACC paper from a few years ago, that it looked at things a little bit differently. This is looking at myocarditis episodes, and patients who have myocarditis episodes and they have a desmosomal gene variant are much more likely to have death, VT, or heart failure in the years that follow than patients with just straight myocarditis and no background genetics, which makes a lot of sense. Like, these patients in red maybe are true viral myocarditis that occurs, and then the insult is gone, whereas patients with desmosomal gene variants continue to have something there that's driving their risk of future disease. I won't get into this today. You could have a whole talk on this, but this is just a super busy slide to show all the different ways in which inflammation is implicated in these diseases. A number of investigators have shown NF-kappa beta signaling driving inflammation. There's TGF beta and MAPK pathway activation. There's macrophage recruitment, so not resident macrophages in the heart, but macrophages from the systemic macrophages that are recruited into the myocardium. There may be autoimmunity happening with anti-DSG2 antibodies, or DSP itself being a self-antigen. So a big question has been, what do we do in these hot phases? They always resolve. And every single patient that we've had who's had a hot phase episode, like they come on, they're there for a week or two, and then they go away. But we're starting to get some, I think, guidance and understanding of this, though it's all been retrospective. So this came from the Desperados cohort as well. It's got a ton of patients in it, 1,000 DSP patients, but only 177 had myocarditis, and then only 63 were treated with immune suppression. But the survival curves like diverged pretty early and pretty clearly. So in red is patients that had immunosuppression, and then the y-axis is any event in the future, which is basically VT, recurrent myocarditis, or heart failure. And so the treatment with immunosuppression made a pretty big difference. Immunosuppression in the study was essentially steroids. Some patients got steroids plus azathioprine. Some patients got mycophenolate mofetil. But importantly, NSAIDs and colchicine didn't seem to make a difference at all. But this is starting to make us wonder, maybe we should be more reactive to these myocardial injury episodes to prevent future events years down the line. So these are just the numbers that came out of that study at 82% and 91% risk reduction. So then the next question, if it helps in the short phase, should we put patients on chronic immunosuppression? And there's no evidence to support that from this. We don't have great data on this, but from that same study, it doesn't seem like immunosuppression prevents repeat myocarditis, meaning that the underlying structural mechanical problem that's driving inflammation and led myocarditis to happen in the first place isn't getting better by giving someone immunosuppression. And there are implications to long-term steroid use or steroid-sparing agents, as I'm sure all of the heart failure folks on the call are well aware of. But it does call into question, like, could we treat inflammation in a different way? Like, would one of these pathways lend itself to targeting with a targeted therapy? And I think there's a lot of people thinking about this and working on it right now. So how do we manage desmoplakin and plakophilin 2 patients at U of M? This is like very much expert opinion. There's not guidelines to help us here, really. So most of this is extrapolated from heart failure trials and I'm sure that this is pretty standard across the board because we don't have other things to reach for. But I think beta blockers are important. Getting back to my idea of mechanical stress and mechanical injury, like maybe they're reducing wall stress, maybe they're suppressing arrhythmias. They seem to drive down PVCs in some patients. And then angiotensin receptor blockers, especially if patients have fibrosis on MRI. Now there's some data for this in HCM from the Vanish trial where valsartan showed a decrease in progression of disease in genetic positive HCM patients. That's like, I recognize kind of a stretch to compare ACM to HCM, but there is some data there. And then exercise restriction, I think, is a big point of discussion. It's pretty clear in plakophilin 2 cases that we should probably be restricting patients from exercise. I think Hugh Calkins at Hopkins, who has thought about this disease and seen probably more of these patients than anyone in the world, is very restrictive in terms of exercise. If you think about the plakophilin 2 patients that you may see in clinic, many of them have a history of aerobic exercise, marathon runners, cross-country runners, things like that. And so I think in PKP2 cardiomyopathy, I'm more aggressive than anything else in exercise restriction. And that's kind of saying a lot. I come from an institution that I grew up at an institution that has been very progressive in the attempt to get people back to exercise, especially in hypertrophic cardiomyopathy. But I do think in PKP2 cardiomyopathy, we need to be careful. And so no, patients can't run marathons. Like, you need to be careful in the weight room, that sort of thing. It's a little less clear, I think, in desmoplakin cardiomyopathy. There's not the same like objective data that's been published, so I'm a little bit more lenient, but I think we may see that change in the future. And then there's a little bit of data out there on SGLT2 inhibitors. This is a study out of China, I think, that looked at DSG2 knockout mice. So not exactly the same gene, but it seemed like SGLT2 inhibitors in a like glucose independent manner affected or rescued their phenotype. There's probably more to come on SGLT inhibition in cardiac disease. There's a ongoing trial that's enrolling for SGLT1 inhibitors in HCM. There are SGLT receptors in the heart, and maybe these will play a role. We don't have a lot of data for ACM right now. Arrhythmia management is super important in these diseases because they're very arrhythmogenic. I think like getting back to some of Melanie's points about genotype and phenotype correlations and variations, we're starting to develop a wealth of data about genotype specific risks. So there's risk calculators now for DSP and ARVC. There's risk calculators for filament C, lamin, like the genotype specific decisions can be made. And so we rely heavily on those. I think just a chance to plug the importance of MRI in DSP cardiomyopathy because patients can have fibrosis before systolic dysfunction. And so when you think about family screening, you can't just get away with your standard echo and EKG in these patients. At least I would argue that you should not for DSP especially. You need an MRI and you need a 7-day monitor to look for PVC burden. PVC burden predicts risk, and I think it's a good way to understand how the disease may be progressing in a pretty like non-intrusive intrusive way. And then EP, our electrophysiology colleagues are super important in both of these diseases. I'm not a EP, I don't do VT ablations, but we have a few people here that we work really closely with. The ability to do epicardial ablation is really important, especially in desmoplakin cardiomyopathy, because the fibrosis is subepicardial, and sometimes you just can't get to that foci from the inside. It's important in ARVC as well, so having the ability to go epicardial for an ablation is important. Flecainide seems like it's beneficial, especially in PKP2 ARVC. There was a clinical trial that they ran out of Rochester that I think is finished, but I don't know that there's a definitive publication on it yet. But we lean on flecainide pretty heavily in PKP2 ARVC. I know despite the worry about structural heart disease and whatnot, but it seems to be helpful. And then the combination of flecainide and sotalol seems to also be pretty helpful and efficacious, especially in PKP2 disease. There's additional things coming. There's this glycogen synthase kinase 3 inhibition small molecule, which I think you guys, at least Ottawa Heart Center, might actually be enrolling in. There was an anti-CD14 therapy that was being run out of St. Louis, but that is on hold. It was a super small study. And then I just found this yesterday. There's an atorvastatin trial in Italy looking at whether or not statins have any effect on RV free wall strain. And then gene therapy is coming for potentially both these diseases. It's, I think, here for PKP2, and maybe there's something we can do for DSP. We've been lucky to participate in the PKP2 trials here at U of M and have treated 6 patients with PKP2 ARVC with gene replacement therapy. Basically, they get virally delivered PKP2 gene in an AAV vector. It's pretty well tolerated. It's not a total walk in the park, but it's pretty well tolerated, and it seems like it works, at least in the sense that it's replacing PKP2 in their heart. This is a picture of post biopsy in green is PKP2, and it's increased at intercalated discs compared to pre. And then on Western blot, the amount of protein is increasing 71%, 115. I think the sponsor did something with these. They messed up these Western blots, unfortunately, because there's other evidence that protein was increased. But then patients 6 and 7 are up, and then the subsequent patients have increased too. So it seems like gene replacement therapy can at least get PKP2 back into the heart and put it in the right place. We'll have to see if it makes a difference in the long-term disease outcomes. And then here in our lab, we can increase desmoplakin in heart cells. These are little microbundles of heart tissue that we work with, and we can drive desmoplakin up with CRISPR activation. Desmoplakin's too big to fit into viruses and directly replace. This is a long way from the clinic, but maybe at least proof of concept that we can drive desmoplakin expression higher using some of these more advanced techniques. So conclusions, I think it's important to recognize that PKP2 and DSP cardiomyopathies are distinct clinical entities. They both have acute and chronic inflammation, but at least my personal opinion is probably structural damage that's driving it, and inflammation is secondary. We probably should be immunosuppressing hot phase myocarditis episodes. We shouldn't be immunosuppressing people long term. Lean on heart failure guidelines for basic management. Genotype's important for risk assessment in all of the ACM diseases. And then I think there's some super exciting therapies on the horizon, both from an inflammation standpoint and gene therapy. And this is all the people that help us do what we do here. We have a pretty big group that thinks about arrhythmogenic cardiomyopathy, both in the clinic and in lab. So a lot of this wouldn't be possible without them. And then our patients are awesome. They're super involved and super eager to find cures for things like this. So they are always helpful. Anyway, that's what I have. So any questions, you guys?
Thank you very much, Eric. This was really a great overview of that complex and rapidly evolving disease. While questions come up on the chat, if you can, maybe Annie and Melanie, you can also rejoin us on screen because there might be questions for you. I have tons of questions for you, Eric, but I'm just going to ask one. It's about immunosuppression because this is something I struggle with a little bit clinically with these patients. Because there's data retrospectively about immunosuppression, and it's interesting because this morning there were talks about steroid prescribing stewardship because of all the potential side effects that we actually see in real life and which can have like severe consequences. So I'm a little bit reluctant to give steroids to these patients. So I was wondering, what do you do with those? Do you prescribe steroids with those? What's the duration, or do you go with cortico-sparing agents right away, despite like less evidence? What's your own approach to this?
So we've done two separate things. I think now these episodes don't happen that often. Like we have a lot of DSP patients, and it's only a few times a year that we have to deal with it. But we're starting to treat this like almost like heart failure rejection, where we hit them early and hard with like a milligram per kilogram of solumedrol for 3 days, and then taper them over the next week to 2 weeks, but keep it short. So just in the acute episode, and then nothing after that.
Thanks. Very useful. I'll probably call you next time it happens. Often what happens is that you have a myocarditis patient and then you do genetic testing, but once you have the result, the episode is almost over. Our delay in Montreal, if we ask for an urgent result, is approximately 1 month. So the episode is resolved then, so it's almost only recurrent episodes that we can know that this is what's going on.
Yeah.
Thank you very much. I see a question from Simon Hansen. Please go ahead.
Hey Eric, fantastic presentation. Thank you so much. I spoke with Alessio Gasparetti a couple of months ago because I managed to chair a session with him, and I asked him the same question about immunosuppression. Are you doing it as a research protocol or standard of care? And how are you counselling the patients, picking them up when they're having an acute exacerbation? Are you preempting them all and warning them what to look out for, or how are you picking them up?
Yeah, I think a lot of times they get picked up. A lot of times, like what Max said, they get picked up as an initial episode and we miss it. So we don't get genetic testing back for a month. My personal patients were counseling about chest pain and that like this can happen to you and we need to be aggressive about treating it. And then we don't have a research protocol right now. It's really just me and Adam Helms that are managing these two. So the two of us kind of decide what to do. And sometimes we'll touch base with the heart failure folks who are more comfortable with immunosuppression than us. But it's kind of a one-off thing right now.
Okay. And as a follow-up, how many people do you get referred, for example, who are presenting with a recurrent pericarditis, maybe who haven't even had genetic screening performed. Are you seeing those patients? Are they being flagged to you as potentials, or how does that work?
They're starting to be, because we've like developed a reputation around here. But the number of like, it's probably like, I don't know, two patients a year that present in like a massive myocarditis episode that we catch and then get involved in. So it's not a ton.
We actually have one in the CCU that Annie and I are betting is desmoplakin, but currently diagnosed as myocarditis, bounce back quickly, VTRS at a hospital. But as Maxime was saying, by the time I get the result, his acute phase is gone.
Yeah.
So I'm not giving him immunosuppression currently in the CCU.
And I think I'm on board with the steroid, the sparing, or like not, you can't just treat all myocarditis with steroids. That's what I'm trying to say. So it's just we're stuck not knowing for some of them. But I do think there's probably harm in slamming every myocarditis case with steroids and not knowing the underlying cause.
Yeah, the other one I guess I would ask about is cardiac sarcoid, which is the other case I've had a couple of times where somebody in my clinic was kind of labeled as isolated cardiac sarcoid, had a fluorally positive FDG PET. And then, you know, because of family history, I ended up testing and ended up being desmoplakin. So how's your sort of your approach in teasing out, I guess, these cardiac sarcoid patients or these labeled, bringing it up back to Annie's acquired cardiomyopathies, myocarditis patients, and trying to educate, I guess, your general other colleagues of when to kind of look a little deeper.
Yeah, I think we've pretty much convinced everybody here that like, you cannot have cardiac sarcoid until you have negative genetic testing. And so like there's a couple heart failure people that are more of the sarcoid folks around here, and they're like well on board with that. And so I think for the most part, nobody at University of Michigan gets labeled cardiac sarcoid until they have negative genetic testing. And they go as far, like nobody's biopsied for sarcoid until their genetic testing is negative. And I think that's the way that it should be, because you pick up so many variants. And it's more than just ACM. Like we one of the residents I work with is going to have a poster at ACC. We looked at all of our FDG PET scans here. We had like 1,500 people or so and 300 genetic tests, and a bunch of MYBPC3 and Titin variants in patients with low-level inflammation. So these other diseases have like an inflammatory component too. But I don't know, you better not call somebody with an MYBPC3 variant cardiac sarcoid. Like that's a problem. So genetic testing is super important.
All right. Well, on that note, I'm going to say thank you for all of our speakers for a great overview, and thank you for the ones who stayed until the last hour. We will be back next year for 5th annual Rare Cardiac Conditions Conference. Please feel free to email us any suggestions of things you want to hear. And thanks again to Maxime for co-chairing.
Thanks to all the presenters and attendees. Have a great evening.